the second one, if this is okay with the chairperson. And this will focus now on CCTA also, CT coronary angiography and hybrid, because these go together. Now if you look at this increasing radiation burden in the US population, you will see that within about 20 years or so, there has been a considerable growth. And a big part of the growth has been to do with nuclear radiology. That has increased substantially, but also CT has increased very dramatically, and a big part of that is cardiac CT. So we really have to care for that, because that's our business that has increased the radiation burden to patients. Now, headlines, there have been plenty of headlines. I show you the verse. CT kills 1 in 1,000 patients. That's what they tell me. They come to me and say, you kill 1 in 1,000. I tell them, oh my God, it takes 3 months to kill so many patients, because my colleagues in radiology do about 50 CTs per day or 100 CTs. How many patients will they kill? But it gets even worse. CT gives as much radiation as a survivor of an atomic bomb got in Hiroshima. That's what people say, and I will show you there are papers publishing this and documenting this. I just wonder how they did the dosimetry that morning in Hiroshima. But anyway, I'll take you through those thoughts. I think this makes us this forces us to be alert on this topic. It's very important. The two main problems with the CT coronary angiography, there is image quality and there is effective radiation dose, and the two of them act in the opposite direction. These are the dose parameters. I go quickly through it, but DLP, the dose length product, is a very important measure. That's what we can measure, and then we can calculate with a conversion factor for just the effective dose. I go over it because you are all experts in this. Just remember that there is a factor, and there is there is a controversy whether this factor is 0.017 or rather 0.014 or rather 0.02. If you read millisievert in CT, make sure you know what conversion factor they have been using, because if you just simply change the conversion factor, then you have what people believe is a dose reduction, but it simply changes the conversion factor. So we have to be clear on what we measure and what we calculate. This is a calculation. We measure the DLP and then we do the rest. Now, how do these numbers compare between the different techniques? And SPECT and thallium, as mentioned, is at the upper end, 20 millisievert. SPECT with technetium in the range of 10, PET FDG 6 to 8, PET ammonia about 3, and I believe rubidium is in the same range, maybe even lower. There were new calculations, because about 5 years ago we all thought that rubidium was higher, but the new calculations have brought this dose much lower now. Now CT, and I think that's an interesting part. We started in 2005 or so with 25 millisieverts, and then with the modulation, a little bit of modulation of the tube, we brought it down to 15 millisieverts all over the world. And here I would like to show you how this can be done. How can we save radiation with the CT? Now you see here a helical scanning mode, which means we have been, this is the beam, the pink bar is the beam. We scan throughout the heart action, throughout the heartbeats, and we scan everything, although we just need a little bit of it. This was then ECG modulation of the tube currents, and that means you go up and down. You go down with the radiation, with the beam, and then you go up again, and the hope was that you can go up very quickly and very steep, but in reality it turned out that this sometimes takes a lot of time, and then it takes a lot of time to go down, and your gain therefore was minimal. We looked at how low it can go. Can it go to the 20% of the max or to 4% of the max? We looked at both. We have randomly assigned patients to this, and we have looked how broad the padding must be for that. We have randomized patients to 20% and to 4% and looked at the results here. I can show you here the pictures. Of course, with 4% the pictures are noisy, but if noisy pictures are fine because you don't need them, this is okay, very noisy. You cannot comment on the LV function anymore, and with the 20% of course you can, and with 100% you get everything, but you could do that with echo with no radiation. And so we looked at it and found that with the 20% of course we have a lower dose with higher heart rate, because the higher pitch seems to compensate for larger window at a higher heart rate. And we looked at the radiation dose, which was the lowest with, if you go down very, very far down. This is obvious and it is feasible, but the difference is not that huge. So we brought it down from 15 to just under 9 millisievert, and at that time we thought, wow, that's a success. But then we had an idea to look, and a colleague of mine looked all over the world about radiation in all the countries, in many different countries with many different vendors, and he found that the radiation went up to 40 millisievert, and in some places even reaching 50 millisieverts or so, because they were not doing it very nicely. And there is all different things that you can do: exposure control, EC, tube currents modulation, tube voltage modulation, sequential acquisition. And I would like to show you what impact this had. First, I would like to mention this. New scanner generation made it possible that if you switch on the beam, your radiation goes up quickly, and when you switch it off, it goes down quickly. Because with the older techniques, it went up slowly and it went down slowly, and the gain, as mentioned, was then only minimal. But here it can go up and go down, and your gain is maximal. But this was not the end. We looked in my group in detail what the coronary arteries do during the heartbeat, and we realized that there is one place where most of the coronaries are moving the least, and all at the same time. This is the best phase to do a CT angiography, and therefore we decided to do and introduce prospective ECG triggering, where we would trigger just that very moment with a very narrow padding. So the beam, which was originally very large, is now limited to this, and the idea is that we catch a picture of one block, and then we move the table, take the next, put it together, take the next, and that's the heart. And we have a fraction of the radiation that we used to have before. This was the very first patient ever scanned with this, and it had a perfect image quality. We did not need to do 1,000 to get this quality. It was just the first, which was wonderful, and from then on we only did this. 1.3 millisievert, that's certainly much less than it was before. So this was a breakthrough because it was a power of magnitude almost to the start. And so with this we can now do CT angiography, and it is feasible. We can now use it broadly, not only for the elder patients, for the younger particularly, to rule out. It's much lower than nuclear, it's much lower than invasive, much less dangerous than invasive. And we can look at the coronaries. We had a lot of other groups joining us in this, and also from our group we had some success with this. It was even translated in other languages because it has raised some interest. It's not only feasible, it's also accurate. And we showed the feasibility in hundreds of patients, first of all, and we also showed that it is accurate, because nice pictures, it's one thing, but it has to be accurate, and it has a prognostic impact. We can predict outcome with these prospective triggering low-dose CT coronary angiography. So it is feasible, accurate, and it has prognostic value. And however, you need a low heart rate. Below 65 is the best, so we give very often beta blockers, that's crucial. And then the accuracy is as high as the other studies with single center studies, which have usually a much higher sensitivity and specificity than in multi-center trials. We have a BMI adapted protocol, which means that patients who are very slim, they get much less radiation, and the more obese, who need more, they get a bit more. Another prospective triggering approach is what you can do if you have a dual source CT. You use exactly the same trick. You try to trigger in here, but your speed of your helical of your CT is so fast that you're trying to cover the whole heart. So this is a prospective high pitch spiral, and that is also feasible. We also have tried to combine stress-only SPECT with the prospective CT coronary angiography, because we thought that this combination would also save radiation, and this combined imaging with stress-only SPECT plus CT coronary angiography is an attractive alternative, because if you can find a defect, and you can find in the perfusion, and then you see the lesion in the CT, there is no real need of doing an additional REST scan. We have done a clinical study with that. We've reduced those short protocol with stress-only SPECT and low-dose CT for patients who come to rule out or rule in coronary artery disease, and we have shortened the protocol, and we've done image fusion. The decision, the endpoint was the decision based on hybrid images compared to the decision taken by the interventional operator in the cath lab to do or not to do revascularization. And we did a one-day stress protocol. We did early imaging instead of the 19-minute delay. We did immediate imaging, and it was a dual head detector camera at that time with iterative reconstruction, and we used this approach of hybrid imaging, which we have developed in our center in 2007, and we found in the hybrid cardiac 21 coronary vessels with 16 patients with a lesion and invasive coronary angiography, We had also 21 core lesions in 15 patients, so a little bit of variation. And the key message was that per patient and per territory, the sensitivity and specificity to find a lesion with ischemia, not just a lesion, but a lesion with ischemia versus a lesion which needs in the cath lab treatment was very high, and the protocol time was 60 minutes, and the total effective radiation dose was 4.4 millisievert, which compares well to the 8+ millisievert in invasive coronary angiography for the pure diagnostic angiography part, of course. So this is the components, attenuation correction, CT and SPECT, and that's a rather low radiation dose and a short protocol time. And it is rapid and it minimizes radiation for an accurate testing. This is one of those examples. Just wanted to show you 2.6 millisievert here in this patient to depict his lesion plus his perfusion abnormality. In the angiogram, I'm not allowed to tell you how much radiation it was. It was much more than 10 millisievert. One of the guys here was the interventionalist. That's why I can not tell you exactly the number of millisievert, but it shows that with low dose hybrid imaging you can be very precise. Now the headlines here, if you look at this, Brenner, who's an expert in radiation, he looked at the radiation exposure in Chernobyl, 13 millisievert as an average. In Hiroshima, apparently the survivors got 13 millisievert. It's good to know, it's a number that at least we need to know that this has been published. I do not know how accurate these measures are, but he's an expert in the field. And of course we read all the time, this was in JAMA, they said a CT scan in a 45-year-old would confer an estimated risk of 0.08%, which is a high risk, he says. But if you compare now this with prospective gating would have less than 0.02 because we are much lower than this. Sorry for that, it jumps. Amazing. And the procedural risk, if you compare it with angiography, the procedural risk is always forgotten, but is very high. And plus the radiogenic risk of angiography, so you would end up, if you do an angiogram, to much higher risk. I think we have to know this because it's always forgotten that in invasive cardiology you use a lot of radiation. The vendors, they know that this radiation is an issue. Look at the nice pictures they do, flowers and nice colors around the scanner, that you forget that there is radiation behind, that they make advertisement with low radiation. I think it's important that we do lower the radiation, and I would like your judgment. Look at the 3D volume banded CT here. Which one would you prefer? I would prefer the MBIR, because I can see the difference between the contrast in the left and the right ventricle. But I leave it up to your judgment. Maybe you raise your hands if you think that the right one, the ASIR, is better quality. Who would opt for that one? Who would prefer the left one? Who is for left one? Okay, so and for the right one, who is for the right one? Okay, a small minority. I would like to show you the radiation dose. The left one is done with what is called model-based iterative reconstruction. I just got the first pictures last night from my lab. 0.19 millisievert. I was sitting there with Michael when I got these pictures. And this is the future. And we did about 30 to compare with the standard CT, and we did 20 to compare them with the CAT. It works wonderfully. This is as much radiation as you get from one anterior-posterior and one lateral simple chest X-ray, not a CT. That's as much radiation or as little radiation as that. This is with new iterative reconstruction algorithm. I think that's the future. In the future, we will do the CTs with that. In conclusion, ECG-gated tube modulation for CT is of course a must. Prospective triggering is well established for massive dose reduction. It works for all scanners across all vendors. It can be combined with nuclear perfusion imaging. The high-pitch spiral is very promising and an excellent alternative, but it works only if you have a dual-source CT, while the prospective triggering per se works in every scanner from every vendor in any model. New iterative reconstruction algorithms will allow further improvement and dose reduction. And these iterative reconstruction algorithms, and that's why I'm talking about both here, those have been borrowed from nuclear medicine, because in nuclear medicine we used to have low photon flux situation, and therefore we have been working on iterative reconstruction. And I told the vendors over the many years, because I was working with both. I told the divisions of CT and the divisions of nuclear, you have to sit together. That they don't want, because that's a business unit and that's a business unit, and they're fighting each other. But I told them, you don't have to fight. You have solutions which are fruitful for the others as well. Iterative reconstruction from nuclear has now been adopted to iterative reconstruction for CT. After all, CT is also a scintillation. You induce a scintillation on the detector, so it's all nuclear at the end. And we should endorse it and fight for it and look for the best test for our patients. The new algorithms will reduce those in CT massively. This is excellent for nuclear medicine, because if you for CT, you use very low radiation, no one can tell you that you shouldn't combine. I would say low pretest probability, we do a CT, we rule out the lesion. If we have a lesion, we do nuclear. And it's no problem to combine a CT and a nuclear if CT is as low as 1 millisievert or even 0.1 millisievert. And the nuclear also should reduce radiation as much as we can. And then we have excellent possibilities to evaluate all the patients very comprehensively. If they have lesions, we do a nuclear test. If there is no lesions, we stop. And this is, I think, what we should do in the future. And this is a very, very next future, I believe. Thank you very much.